This conference will now be recorded.
Morning for me, good afternoon for you. So thank you so much for inviting me to give this presentation today. It's exciting when I give AMSTAR presentations because it's not what I get to work on all the time, but I certainly love when I get to share the work that we did for the last over probably a 10-year period, I think you'll see, or longer. So I'm very excited to be able to do this with you. And feel free to ask questions throughout. I going through the end is really long, so I prefer if you have questions, especially when I get into the instrument itself, if you have questions, blurt them out, because I think that's even better. So I live in Ottawa, Canada, and it's just starting to get a little bit warm now in the last day or so. It's been pretty bitter. So anyway, I miss traveling, and I certainly miss traveling to Africa because I did a lot of that. This AMSTAR development team is massive. Some of these people you will recognize from the Cochrane collaboration, and I don't know if people actually knew that I developed AMSTAR 1 as part of my PhD in Amsterdam. That's not where the name came from. But the AMSTAR 2 then was an operating grant that I'll tell you a little bit about. So you'll recognize some of these people who are sort of play very senior roles in the Cochrane collaboration. So they had a lot to do with the development of this instrument. So for AMSTAR 1, which was like 10 years ago or more now, we did a lot of work reviewing the published instruments, because you can't really develop, people forget that you just don't sit down and on the back of your sheet kind of write the items. You have to know what you're putting into these instruments. So the published literature and the psychometric work prior to us coming on board, or anyone coming on board, is very important. So we did a lot of methods work at the beginning. We looked at a large sample of published instruments to develop AMSTAR 1, and we did retest reliability and feasibility and usability and all the other things that you do when you're developing an instrument. And then we called it an AMSTAR tool to assess the methodological quality of systematic reviews, because that's where AMSTAR came from. And everyone said to me, well, you're doing it in Amsterdam, you can call it Amstelveen, you can call it Amsterdam. And I was like, no, this works, and people love the name AMSTAR. And the name actually came while believe it or not, while I was on a trip from Ottawa, Johannesburg. Someone is not muted there. While I was on a trip from Ottawa to Amsterdam, I came up with, Johannesburg, I came up with this name. So believe it or not, you have affiliation with the name, because that's where it, so it's very fun doing this. Then we published a series of papers on amstar.ca and in several PLOS and BMC and others that we published the AMSTAR 1. But it was widely used as whatever they wanted to use it for, a critical appraisal tool, for randomized and non-randomized, and it wasn't developed for that. So we decided that we needed to update AMSTAR 1 to AMSTAR 2. So that's how we put in the methods work for that. Also, what happened, the reason that we were also went from AMSTAR is there's a lot of risk of
Sorry, can you please keep yourselves muted? I'm trying to find the person that's...
There was a lot of current trends on risk of bias and developing individuals' tools for assessing risk of bias of the individual studies and systematic reviews, like Robbins I, which is for individual non-randomized studies. And I was also part of the development of that. You'll see that AMSTAR 2 and Robbins I go together very well. And ROBIS, I was also involved in developing ROBIS because they were looking for something that kind of was for overviews of systematic reviews, but it included specifically risk of bias, but everything for, ROBIS is, well, I'll show you. What we were missing, though, is kind of this critical appraisal tool that people could use to make it easier to look across kind of the internal validity, reporting standards, conclusions, and generalizability. So we were missing that kind of tool that could do that. So people kept asking for to use AMSTAR as a critical appraisal tool. So why not develop it for that? So that's where AMSTAR 2 grew from, this kind of pragmatic place of using a critical appraisal tool to assess this body of evidence. I used it a lot in teaching. I'm sure others have, especially within the Cochrane collaboration. They do a lot of teaching of the methods. And so we used a lot for teaching and training people how to conduct systematic reviews. So it had a role and a place there as well. So ROBUS, as I said, I don't want to not bring up that there is, this other tool that people are using at the moment for assessing bias in systematic reviews. It was published in 2015, and it provides guidance on if you're doing an overview as well. So similar to systematic reviews, or AMSTAR. It looks at all the different components of specifically risk of bias, and you can use that for other tools. There's a lot of information on the ROBUS tool and the Robbins tool, etc., on robust.tool.info. And so you'll see how all of this now fits into the new tool, AMSTAR 2. So again, I told you that AMSTAR was originally published, so it was my PhD in Amsterdam, but it was also I was also playing a big role in the Cochrane collaboration in looking at risk of bias and critical appraisal. And so like I said, the name came from my trip to my first trip, I think, or second or third, to Johannesburg and other parts of Africa. So they were part of the methods work that we did in the beginning. And it provided guidance for rating the quality, specifically methodological elements of published systematic reviews. It was initially developed, so that was like a 10-year period there that we finally got AMSTAR 2 out of it. It was initially developed to appraise systematic reviews of randomized controlled trials. And that, as people know, is not a good way to go, because lots of the literature at the moment, specifically like in a time right now where the COVID, they were looking for non-randomized in other areas as well, where not everything is a randomized controlled trial. And so we needed AMSTAR to be able to assess systematic reviews, including non-randomized studies of healthcare interventions. So that's how we got AMSTAR 2, comprising of 16 items, and each of these provides a single sentence or question with additional guidance. And then we expressed it as a yes, partial yes or no, and I'll show you that in a second. So the aims of the redevelopment was to maintain its critical appraisal, usability, and self-explanatory as far as could possible. So it's probably a little more complicated than I want to have, but we needed that to kind of keep the components that was necessary, and you'll see. So it was more comprehensive, included non-randomized studies, included the risk of bias evaluation performed by reviewers, and then we altered the scaling of ratings as well. So we had this method study group. I think anyone who's developed an instrument, or particularly Cochrane collaboration, people know exactly how these kind of development teams work and how the methods work. So we had a local study team. We actually did have a successful CHR grant. So that's, the CHR is our Canadian Research Institute funding body. It's really hard to get an operating grant for methods work, but they saw the value of something like AMSTAR, the development of AMSTAR 2. So we did get an operating grant for that. So then we looked at all the coverage of non-randomized studies of interventions. We did a literature review. We got feedback from many users. We did survey, line-to-line review of the instrument, or the original instrument, and then we looked in line how those responses aligned with yes. But also, because Robbins Eye by this time, it wasn't available when we did AMSTAR 1, but now including non-randomized studies as part of AMSTAR 2, we could use Robbins Eye. So we had several investigators who were part of both teams, so that was really valuable for us as well. We also had a nominal group process where it was at our Ottawa Hospital Research Institute. The initial one for AMSTAR took place in San Francisco at a big rheumatology meeting where I had done this nominal group technique and questions. So for AMSTAR 2, we did the same thing. We had a group in Ottawa, though, and they, went through all the questions and did round robin recording responses, and then we had a group discussion and voting. So we did also have that for AMSTAR 2. So some of the questions, like, are questions appropriate? Are they easy to understand? That's kind of the questions that we had asked them in the nominal group. And so if you have done focus groups or nominal groups or cognitive interviews, this kind of helps you to, really get the feasibility of what people think about the questions. So I don't, want to go too much. I'm going to tell you a little bit about the reliability and usability at the moment, but I thought I could go through the instrument with you because I think this is the most important part for you. So it's a critical appraisal tool that includes randomized and non-randomized studies. Did anyone have any questions on the first part?
No. I don't see any questions in the chat. If you do have a question, feel free to post it.
Yeah. So, so as I said, we had 16 questions, and I thought it's easier to just go through those and let people kind of have a feel. If you haven't, I didn't ask at the beginning how many people hadn't heard or read or used AMSTAR, but if you haven't, this will help because at least you'll get a feel for what we're thinking about within each of these questions. So number one, obviously, did the research questions and inclusion criteria for the review include the components of PICO? And so PICO, as you know, is kind of you can't do anything in a study or a systematic review without defining your PICO. And so we thought, well, if that's our starting point for conducting a good or high quality kind of systematic review, then we needed to ask the question about how well they did it. So for a yes, if they included everything, the population, intervention, comparator, and outcome, they would get a yes. But time for follow-up was also important for us. And so some people I know, they look at things like the design or setting, which is also important, the context. But for us, we were looking at the time frame for follow-up as well. And that was just a recommended optional. We didn't put partial in here because we thought they either have to define their PICO or not. If you haven't defined the PICO, then it's a problem. So we didn't need the partial. We just said it's yes or no. So did the report of the reviews contain an explicit statement that the review methods were established prior to the conduct of the review, and did they justify any significant deviations from the protocol? So some of this will look familiar to you because we do a lot of this stuff within the Cochrane collaboration as well. We think about these kind of things. So for partials, the authors had to state that they had written a protocol or a guide that included all the following: a research question, a review question, the search strategy, inclusion, exclusion criteria, and risk of bias assessment. So those what we thought were minimum for including, for getting a partial yes. But that's not where the Cochrane collaboration, we all obviously want people to put the full scope of what should be included in here. And so to get a full yes, they had to also include the meta-analysis plan, which we have to do within Cochrane reviews. But remember, this wasn't developed just for Cochrane reviews. A plan for investigating causes of heterogeneity and justifications from any deviations from the protocol. So you can see how this matches up with some of the other instruments that you'll see in the individual studies. So then that, as for the partial, plus the protocol would be registered and should also have specified all those other things. And so for a partial, they could have those 4 items on the left, and for a yes, they would have to have the other justifications of their meta-analysis plan. Sorry, this is a little bit small. I hope you can read it. I forgot to say that you can follow along. It's in the BMJ, Open BMJ 2017 if you wanted to open it up on your own computers. So did the review authors explain the selection of the study design for inclusion? For yes, the review must satisfy one of the following. So they had the explanation for included only RCTs. Now This is really a big question. Everyone talks to me about this. They're like, we don't always see this in reviews. So for a yes, the review must satisfy one of the following. They must have explained why they included only RCTs. Not that you have to include non-randomized studies. If your question doesn't need to include randomized studies, that's okay, but you have to justify why you only included the RCTs. Or explain the inclusion of only non-randomized studies and not randomized studies, or explain the including of both RCTs and non-randomized studies. So remember, this is not just about assessment. We use this to teach people how to do better, higher quality and better, better systematic reviews. So we thought that this is actually really important for people, because lots of times they'll put in, oh, we included non-randomized studies. And we're like, well, why did you not include the RCTs? And so we ask people to then justify their inclusion. Did the review authors use a comprehensive literature search strategy? So this always, as you know, you think that this is the most simple question, but it always ends up being some, people sort of think it's a little bit strict or it's not strict, and I'll tell you in a second. So of course, at least 2 databases. We prefer others because you have to think about the relevant question. If your question is a nursing question, you'll include CINAHL. If you're nursing, depending on the field it is. So it's at least 2 databases. It doesn't mean that it's only 2 databases. Provide a keywords, of course, or search strategy. Justify the publication restriction like language. So that was for a partial. But we would, really want people to do all the other things that we do within our systematic review search strategies now, like in the search to trial registries, included the content people in the field, search for grey literature. This next one causes a little bit of an issue because now I think it's a little bit different from Messier as well, probably. Conducted search strategies within 24 months of completion of the review. So I think now, this is the update piece. So now some people, I think, say that probably it should be updated within 12 months, or the last search strategy within 12 months. So I might get some comments about that, but this is what we did when we did it. And it's really hard for people to have their search completes and everything completed within 24 months as well. But there we go. Okay, so the study selection and data extraction. Did the review authors perform the study selection in duplicate? So we were saying that at least one of the following, so at least 2 reviewers independently agreed on selection of the eligible and achieved consensus. So the 3rd reviewer would be part of that consensus, or at least 2 reviewers select a sample of eligible and achieved good agreement. For the study selection, you're used to these methods because this is all Cochrane guidance. Did the review authors perform data extraction in duplicate? If yes, select one. At least 2 reviewers achieved consensus on the data extraction or had achieved consensus on the data extraction and good agreement on the sample. So this is what we do now. So inclusion and exclusion and included study characteristics. Did the review authors perform a list of excluded studies and justify the exclusion? So these don't give too much controversy because this is what we do within the Cochrane collaboration. So for partial, they provided the list of potentially relevant studies that were read in full text from and form the excluded review. And for yes, you must have justified. And so when we did this, like even early AMSTAR, we wanted people to not just exclude things, but they had to justify the exclusions that were potentially relevant. And so we do this obviously with the Prisma stuff, and but we just don't want you to say the references that were excluded. We want people to justify why they excluded potentially relevant studies. So I think this group would be used to that. Did the review authors describe the included studies in adequate detail? So did they provide, this goes back to your PICO, did they provide all these PICO items like the population interventions, comparators, and outcomes, so for partial, and their research designs as well. So we have, instead of putting it up into the PICO at the first question, we have put their research designs to get a partial here. But for yes, they must have described the population in detail, the interventions in detail, comparators in detail, describe the study settings, as I talked about earlier in the context, and the time frame for follow-up. The reason this question is actually really, really important is for most of you, you probably, when you're doing systematic reviews, you go to, report on your details and you're like nothing. They just said the intervention, they named the drug, they named the community centers, or they really do not provide details of what these interventions were or the settings that they took place in. And I'm sure a lot of you are always frustrated with that. And so we wanted to make sure that, again, like I said, it's an assessment tool, but it's also a training tool for people. So we really wanted to make sure that that going forward, when people sort of know what's expected, that they do report this very well. All right, so the risk of bias within individual studies. Did the review authors use a satisfactory technique for assessing the risk of bias in individual studies that were included in the review? I'm just going to shine. So for RCTs, they must have assessed risk of bias using, now you're used to this because of our risk of bias too, but people obviously outside the Cochrane collaboration may be using other instruments, risk of bias 1 and 2, maybe using other instruments. So what we want is for people to think about, for assessing an RCT, their uncontrolled allocation and the lack of blind when assessing outcomes. So unnecessary for objective outcomes such as all-cause mortality. And so in our document, you'll see on the website and BMJ and also on our website, I'll give it to you at the end, we have guidance around that. There's several pages of guidance around this tool. So hopefully, and if you have questions ever, just send me an email. So for yes, they must have assessed the risk of bias from the allocation sequence that was not truly randomized and selected and report the results from among multiple measurements or analysis. So those are the items that we felt were very relevant to the RCTs. And then included only non-randomized studies, obviously, because some of them would obviously do just non-randomized studies if you don't have RCTs, or they're not relevant for your question, or you're looking at harms and you needed to use non-randomized studies only. So the non-randomized study questions come from the Robbins Eye tool. So I know that it's a bit more complicated when you're using the Robbins Eye tool, but we have provided guidance within this from our Robbins Eye tool. So for partial, you must have assessed the confounding, of course, is the most important, and your selection bias. And then for a yes, you must have done those two, plus methods used to ascertain exposures and outcomes, and a selection reported results from among multiple measurements or analysis of specified outcomes. So those are the questions that we have chosen from the Robbins Eye. And again, we included the guidance around that. So if you have any questions, let me know. So and then you would have to document whether you just included the RCTs only. So then the conflict of interest statement is, or question is very interesting, because not everybody feels that it should be part of these instruments. But we did feel that because AMSTAR is a critical appraisal tool, not just about, although risk of bias is important for the conflict of interest as well, but we felt that because it was a critical appraisal tool, we needed to include conflict of interest in, and we had lots of examples as you know, that showed the conflict of interest, the relevance of risk of bias relationship to conflict of interest. So we had a conflict of interest statement in AMSTAR 1 as well, but now we have 2, and I'll tell you why. So for the first question, number 10, did the review authors report on the sources of funding in included studies? So they must have reported on the sources of funding in the individual studies. So you must go back to the individual studies and report whether they included their conflict of interest within that. So report that the reviewers looked for this information but was not reported by the study authors also qualifies. So we just want to say whether or not in the primary studies, they did include their conflict of interest statement. And I'll show you at the end how the other conflict of interest statement comes in. So inclusion, if the meta-analysis was performed, did the authors use appropriate, because you don't have to do a meta-analysis, obviously, but if they did perform, did they use appropriate methods? And we're used to this within the Cochrane collaboration, but others may need more guidance around looking at appropriate methods for statistical combination. So for RCTs, if yes, the authors justified combining the data in a meta-analysis, because we have to do that within our systematic reviews and meta-analysis, obviously. So, and they use an appropriate weighted technique to combine the studies and adjust it for heterogeneity if present. And we have techniques within different software that helps us determine whether there's heterogeneity or not. They investigated heterogeneity and interpreted the findings if appropriate. And so yes, no includes only non-randomized, or no meta-analysis was conducted. So that's what you just tick if they didn't. But because we don't add up all this, you don't lose points, obviously, if you don't do a meta-analysis, whereas in AMSTAR 1 you would have. So for non-randomized, yes, the authors justified combining the data in a meta-analysis, and they used an appropriate weighted technique to combine studies, adjusted for heterogeneity if present. And they statistically combined the estimate effects for non-randomized studies that were adjusted for confounding. So I want to point out here that you're not combining the effects that were not adjusted for confounding. You're combining, lots of people ask me this, they're combining the adjusted effects rather than combining raw data or justified combining raw data when adjusted. So they're not available. And they reported separate summary estimates for RCTs and non-randomized separately. And I also know that this is a little bit of, I always have a little bit of conversation or controversy around this as well, because some people are lumpers and some people are splitters. And so we feel that there's a lot of like different quality studies, and just lumping everything together, all the randomized and non-randomized studies, is probably a problem. But if people want to do that, they can. They just need to really make sure that you work closely with a statistician, or someone who knows this data very well, so that you're not giving people the wrong estimates by lumping everything together. So our recommendation is that you combine the adjusted results for confounding, and that you separate and pool the RCTs and separate the non-randomized studies and pool those, and then provide not an overall combined, but the individuals for those. Everyone, though, will have their own opinion about that. So the risk of bias results on the interpretation. So if the meta-analysis was performed, did the review authors assess the potential impact of risk of bias in individual studies on the results or the evidence synthesis? So for yes, they included only low risk of bias. So this is what we do when we're assessing the risk of bias. It's no good just assessing it if you don't do something with it. So we want people to look at the impact of that risk of bias on the interpretation and the results and interpretation, sorry. So they included only low risk RCTs, then we would say yes there. Or if they pool the estimates were based on RCTs or non-randomized studies at the variable risk of bias, the authors perform an analysis to investigate the possible impact. So sometimes they do that. What is the possible impact of this overall summary? So did the review authors account for risk of bias in individual studies when interpreting or discussing the results? So did they include only low risk of bias again here? And or if their RCTs were moderate or high or non-randomized were included, did they provide a discussion about the likely impact of it? And finally, so number 14, we looked at, did the review authors provide a satisfactory explanation for discussion of the heterogeneity? So this is one of the most important pieces when you put everything together, is looking at the heterogeneity. So within, again, we have lots of statistical, I won't go through these statistical, but we have lots of guidance around doing and assessing the heterogeneity. And within all the software now, you'll have statistical results for, explaining the heterogeneity. So if it was present, did the authors perform the investigation of sources of heterogeneity and the results and discussion of the impact of these results? Did the review authors carry out an adequate investigation of publication bias? And remember that you have to have at least 10 studies to look at the publication bias statistically. So did they talk about or did they look at the impact of publication bias? So either they performed graphical or statistical tests for publication bias and discussed the likelihood and magnitude of the impact of publication bias. And I said that for the number 10, where you have to look at the sources of funding for the individual studies. So now this is the overall conflict. So did the review authors report potential conflict of interest, including any funding they've received for the actual conduct of the review? So the authors reported there was no competing interests, or they described the funding sources and how they managed the potential conflict of interest. So that's the instrument. I have some additional slides just about how we did just some of the synthesis and what we do to overall assessment. I'll just ask if there are any quick questions before I go on to that.
Yes, there are a few from the chat.
Okay.
So there's a question from Marianne, and she asks, can the AMSTAR2 be used for umbrella reviews? If not, can you recommend a tool?
Yes, that's perfect. That's what it's used for, because the umbrella reviews, you're going to assess the systematic review. So that is the umbrella review. You can use the AMSTAR2 as your critical appraisal or quality assessment tool for systematic reviews.
Mm-hmm.
Yeah,
great. Then there's a question from Meenakshi about question 1 in the tool, and she asks what happens if the comparator group was not mentioned, but I guess all the other components were mentioned.
If there was no comparator and if they had a comparator and they didn't mention, then they wouldn't get a yes for that. But if there was no comparator, then they would get a yes if it's not relevant. But if they missed mentioning it, they would get a no, because they have to have all those components, the PICOs.
Okay. There's a question from Lloyd, and he's asking, is there any merit in the researchers justifying the databases searched for the review?
So which ones? So like we look at PubMed or Medline or Embase, all the relevant ones, but and that's what we've recommended in the guidance, but it's also relevant to your review, right? So we're saying at least 2 databases. You can have multiple, you can have 6 or 7, but we do suggest, Medline and Embase, PubMed, those are kind of been, right? Those have kind of been what we suggested. Is that what you mean?
I guess Lloyd can speak
Yeah.
if the question hasn't been addressed properly. I know that depending on the field where the question is, you might have to justify more or less
Exactly.
for which databases you're including.
Exactly. So we always add CINAHL to ours, because a lot of the stuff that we do is relevant and comes out of CINAHL. So it depends. And there are so many databases that exist, so it's easier to just include them up front, and that way you don't miss studies. So it's at least 2, but we'll always, depending on the field, you're going to have additional ones as well.
Yeah.
In the question.
Okay.
Yeah, I agree.
Thanks. There's a question for Sharmila. So Sharmila wrote quite a bit, but I think her essential question is about using AMSTAR2 to assess the quality of reviews of qualitative evidence, and whether I think they haven't had a great experience using AMSTAR2 for that, and what are your comments on that, or whether
Yeah.
there are other? Yeah.
It's not developed for the assessing the qualitative evidence. There's a McGill, actually, very good study that looks at systematic reviews of the qualitative evidence. I can send that to you and you can post it if you want. But
Okay.
and there's also something that came out of McMaster. I think Maureen Dobbins' group have done a couple of that for assessing the systematic reviews of the qualitative. But this one, yeah, it's been specifically developed for interventions of RCTs and non-randomized, and that's probably why it wouldn't have worked very well for the qualitative.
Thank you. And Sharmila, please feel free to speak or to type in the text if your question was slightly different from what I understood it to be. Then there's a question from Anna about question 9 regarding risk of bias. She says, for lack of blinding, what about if it's for an intervention where blinding is not practical, for example, peer support? If the systematic review authors have noted that this is not possible for these studies, would you be able to score a partial yes?
Yes, you would. Yeah. Yeah.
Okay, great. That was straightforward. And then another question from Meenakshi about question 10. So she's asking if there's a few studies that haven't reported funding source, but the others did. How can that affect your rating? See, there's no partial yes here.
Yeah. People have asked me to put in if you had, yes, yeah, I agree. It's right. You're right about that. We needed a partial in here. If all or a majority of them have not mentioned, then they would get a no. If some of them had, you can put in partial there, because because it's a critical appraisal tool, we're not adding it up. Other people have asked me that as well. Like, how do we score when some people have done it? I mean, it's difficult, and so because the way I show you that you're reporting, you'll put in, you're not adding it up. So you're going to put in that they've had yes to this study, no to that, yes to that one, right? So if some of them have reported, the majority of have reported, kind of, you can give that a yes. We don't find that majority of them have reported this. But I think you're right. I think we need to change that to a partial, to add a partial in there.
Great, thanks. Okay, and then just another question from Anna. When you're doing the overall scoring, do you count partial yes as a yes?
We don't do overall scoring for AMSTAR 2 anymore. I'll show you how we do critical appraisal. I'm going to show you now how we do assessments for the critical. Yeah,
so I think we can go on for now.
AMSTAR 1, we could do that. We did add up, and they gave partials would go to a yes, but because of the difficulties of adding these instruments, adding the score items within these instruments, we moved on to critical domains. So I can start that now. That's great. Good question. Thank you. So yeah, as I said, we stopped scoring or adding up the items within because of the difficulties, and they hadn't been weighted and stuff. So we set up this protocol, the protocol critical domains. So within those items, the protocol registration before the commencement of the review, item 2, was very relevant, obviously. So we're saying that that is now a critical domain. But we're not sort of saying that you have to say that these are critical domains. If there are others that you want to add to this because you felt that your review, some of the questions of the 16 were very relevant, you can add that in as a critical domain as well. So you can decide, there's some flexibility in if you want to add critical domains, there's some flexibility. These are the ones that we felt, based on the work that we've done for Robin's Eye, Robus, and all the other kind of critical questionnaires that we've been part of developing, that we felt these were the critical domains. So the protocol registration before commencement of the review is very relevant. Having a protocol is very relevant, and we even find that people still do not have protocols. So that number, item 2. The adequacy of the literature search, obviously, extremely relevant and important to conducting a high quality review, systematic review. So that's a relevant one. So item 4, justification of excluding studies. And people ask us why we're so strict on this. And again, if people are used to doing systematic reviews, they realize that they always do justify, you know, with our PRISM and other work that we do, we always do justify the excluded, but we felt that that was also, it's not just about excluding it, you want to say why you excluded it. Because it's about bias and critically appraising your review. So risk of bias from the individual studies being included in the review, that's another very relevant item that we felt. Appropriateness of the meta-analytical methods. If you didn't do a meta-analysis, that's okay, but it's just if not, that these, if you do the meta-analytical methods, then we want to know how appropriate were the methods, how well did you do it. So that's also critical domain, and consideration of the risk of bias when interpreting the results of the review. An assessment and presence likelihood of the impact of publication bias. So these are the ones that we felt were relevant for the critical domains. Then you take those critical domains and we gave it an overall confidence in the results. So what we said was, if one of those, if none or one, no critical domain, then the systematic review provides an accurate and comprehensive summary of the available studies. So if you had no critical weakness, none of those were critical domains within the thing, they all scored yes to those, then they would, this review would provide an accurate or comprehensive summary. That's a moderate if you had more than one of those critical domains. So more than one of these critical domains or domains that you've decided were critical as well. So if they've had more than one of those, then the systematic review has some weaknesses, but no critical flaws. It just has one weakness. So we call that a moderate. So it may provide an accurate summary of the results that addresses the interest. So that we call that a moderate kind of confidence. You probably, if you're used to doing the systematic reviews within Cochrane, looking at grade and Robbins, you'd recognize this. But we felt that giving it, instead of adding it up, giving it this like critical domain and looking at the overall judgment was kind of more helpful than adding up scores and not figuring out what the score means. So low, if one critical flaw with or without no non-critical, then the review has that critical flaw may not provide an accurate or comprehensive summary of the available studies that address the question of interest. And it's critically low if more than one of those critical flaws with or without a non-critical weakness. The review has more than one critical flaw and should not be relied on to provide an accurate and comprehensive summary of the available studies. I'm going to show you in a second just a review that we went through and did this. Looking at the time. So we measured the inter-rater reliability. I don't know if there's questions on the other thing, but just in a second, I'll show you an example. So I just want to show that we had done a lot of, actually there's just a paper came out recently, very recent, on the AMSTAR reliability for AMSTAR 1. So people are still doing lots of methods work. So just so you know, we did a lot of work in the initial AMSTAR development on the inter-rater reliability. We also did it for AMSTAR 2 and use the same kind of technique or approach to have, you know, several people looking, 2 pairs at least, but there's several others who were looking at these comparisons to see, and they applied this to interventions to reduce medication errors, 14 review, and non-pharmacological therapies to just do some reliability testing to, you know, before we could publish AMSTAR 2. It's very interesting that some of the kappas, you'll see in the middle there, the kappa varied substantially. So even people who are used to using this sometimes had difficulty in coming up with agreement. And for those who don't understand the kappa's agreement, it's just like a 0 to 1, and we look at correlations or agreement to, assessing to see how well they agree on these assessments. Some of the people who actually had been used to using this had difficulty, but others no. So some of the questions might have a little bit difficulty, and I think it has to do with the question, because when you're looking at some of the interpretation questions or the meta-analysis questions, especially when you include non-randomized studies, it's difficult. So don't get frustrated if you use it and you're like, well, we did some agreement and it wasn't as high as I had thought. We didn't have as high agreement. But I think over time, having the discussions and working out the questions, don't hesitate to look at the guidance or to call me. But yeah, it's a little bit more complicated when you're assessing randomized trials and non-randomized studies in the same systematic reviews. Don't get frustrated with it. Just we're happy to help to improve your agreement with these questions. So we had just pulled up a little while ago, last year actually, a brief analysis, and I was shocked. I just pulled it out yesterday. There's like 1965 citations in Google Scholar. I think it's even more. I think I probably didn't have that. I'm always just grateful, I think, and surprised at how many people are actually using AMSTAR. So we published the AMSTAR 1 in 2007, and so 10 years later we published AMSTAR 2. But lots of people are using it in lots of citations, and I wanted to just say that it was here's some of the examples, like assessing the quality of multiple reviews, the overview or the umbrella review, as you mentioned, some commentaries, and this is just a small sample of some of that. But this was it's just some of the examples. But this is the one that I really wanted to spend a minute on. So this is how you would report. So this is an overview of meta-analysis on the prevention, treatment, childhood obesity. So this is how, as I said earlier, like how you would report. Instead of having scores now, you would just give everything the yes, no's, or partials. And then you assign this overall quality of low, critical. So the last example, was 4 high quality studies, 1 moderate quality, 12 low quality, and 7 critically quality. So this is a way of synthesizing all the results that you would have done with your review, when you're doing your assessments of the systematic reviews. So we're still needing to pilot test this with the Messier guidelines to make sure that there's no omissions, especially now that it's come out since this. And some of the differences, I think Messier has 12 months for that you guys can tell me that difference actually. But I think they have 12 months for the updated literature search. And we still need to do a bit of validity work as well, obviously. I don't know why that won't move, but I got frozen there. Are you there? So
We are here.
That's it, unless you have questions. I was there. It went. I don't know why it keeps going back there, but that's the website that I was talking about. So on that is your the tool is on there. We're trying to update it. It's not good at the moment, but the tool is on there, and there's also the guidance, the actual tool that you can download, and also the guidance is on there, and the guidance to all the questions. There's something else. Don't use the adding up tool now unless you're using AMSTAR 1. Great. Thank you. Any questions? I'm sure you have lots of questions about some of the overall confidence stuff, I'm sure. Thanks, everyone.
Thanks. There's just one question from Minak. She was asking how to do criterion validity for AMSTAR 2 and construct.
If you're going to be doing a study, you mean?
Meenakshi, do you want to maybe explain your question?
So if you want
she said yes.
Yeah, if you want to do a study to look at the constructs and criteria validity. Is that what you mean?
Yes, yes. I would like to compare it with other tools like Robust tools, so that I would like to see if I have to do umbrella systematic review, which one will be better in my case. So how to go about a validity? Like, we have done the reliability of the AMSTAR 2, and it was wonderful. We found it to be very much reliable, but we could not find any study related to the validity of AMSTAR 2. So could you please elaborate on these two specs which was there in the last slide?
Yeah,
Thank you.
you're right. And you're right about that. So because we felt that we had done so much validity work with the AMSTAR 1, because then we used the Oxman and Guy gold standard as the gold standard. I had 7 groups across the world compare the items to that with this gold standard, and the correlations, actually the interclass correlations and stuff, were actually not too bad for the items within that. And then because there's no gold standard, it's hard, right, to these studies. But you could, unless you consider Robust now the gold standard, you could do this kind of construct validity work with using Robust possibly. But the other thing that we did again is we looked at these for the original AMSTAR 1. Yeah, we looked at developing this overall rating of 1 to 7 because we were adding it up. So I guess there's not really a gold standard, and unless I wonder if we could use Messier, the Messier guidance. Let me think about that a little bit more. But we put in the paper that because we had done so much work on the items, a lot of the items haven't changed. It's only the non-randomized study. So we wrote that because we had done so much groundwork doing this large international study, looking at Oxman and Guide, comparing it to AMSTAR and the correlations around that for each of the questions, that we didn't feel that we needed to publish it to do the validation work. And AMSTAR 1, I'll also say, is also built on a factor analysis. So the items themselves, we've added the non-randomized component, but the items themselves hadn't changed from the original factor analysis. So but I like your question. Let me think about that a little bit more. Maybe we can help.
Great, thanks.
Do you want to send me an email? Do you want to send an email to that email, and we can talk about it a little bit more?
Great, thanks so much. I hope you take advantage of that, Meenakshi. And just checking if there are any further questions from anyone. Okay. So we are almost to the hour. So thank you so much for this presentation. It's really interesting to see how it's developed. I mean, we all use it quite a lot in our field of work. So thank you again, Beverley, for doing this webinar for us. And everyone, I sent a link in the chat box with a link to the evaluation form for the webinar. So if you could follow that and complete it, that would be great. It will help us with future webinars. It will also be circulated when we circulate the presentation. Thank you so much, Beverley, and thank you, everyone. And I'll see you soon.
I just want to say thank you for inviting me, and thank you for using AMSTAR. And I'm very, 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 like I said, grateful for people who do use it, and we're happy to answer questions anytime. I'm always, at the end of an email or phone call. So yeah, so thank you.
Great to know. Thank you.
I hope to get back to South Africa someday soon. So stay safe, everybody.
Soon. Let's hope so. Enjoy the rest of your day. Bye, everyone.
Bye.